I see the participants queuing up. Good evening, everybody. Just giving a couple of minutes for the participants to fill up, and then we can commence, Professor. So just, I think we'll give a couple of minutes. Is that okay?
Yeah, fine for me.
Can you check your microphone, Professor Hesham, please?
Your microphone, I hear you well.
Your.
I'm fine. Do you hear me well?
I hear you well, but there is some noise around you. I mean, the voice is not as clear as before. You are using the.
أنا بستخدم لكل مرة، سامعني كده كويس؟
سامعك بس في صوت تحس إنه عامل إيكو شوية.
Yeah, it does sound a little bit.
Yeah.
I can use only one. This is better?
It's still the same.
Still the same. I will change the audio setting, okay?
If you can, please.
I do echo cancellation and an aggressive platform. You hear me well right now?
I hear you, but not like the last song. No, I last lecture.
It does sound, I'm not sure what happened, but it does sound a little bit muffled or...
Yeah.
Muffled?
Yeah, it seems to be like this.
Now, you can right now, is it okay?
لسه برضه في حشرجة شوية يا دكتور هشام. أنا مش عارف من السماعات غالبا اللي عند حضرتك.
كده هو كده طيب أخباره إيه؟
I think it's okay, دكتور خالدة.
We can understand and it's clear and it's not breaking. Though you were clearer before, so I'm not so sure what happened, but we can hear.
Okay.
Yeah, we can hear.
Is there any echo or?
You've become clearer.
Clear, okay.
So I'm thinking, what do you think, Professor? We look like we have a good cohort of people. Should we just start?
Yes, we can start right now.
Okay. So good evening, everybody, and thank you for taking the time to join us on this wonderfully interesting topic and this excellent panel that I'm just privileged to be amongst. We do have as part of our panelists Professor Francois Cazet and Professor Said Khamis, who I will introduce a little bit later. But I have the honor right now of introducing Professor Hesham Elsayed, who many of us know, emeritus professor of nephrology at Ain Shams University and head of the nephrology department at Ain Shams University. And he is known to me as the president of the African Committee for COVID-19 Pandemic and the editor of the first Egyptian hemodialysis guidelines, which we are trying to adapt for African guidelines. And he is the head of the hemodialysis committee under the African Association of Hemodialysis. And he has so much experience in terms of being a teacher and in terms of being a guidelines editor and in terms of being a researcher. So we're so honored, Professor, to have you here with us and to make this presentation for us on hemodiafiltration and its applicability in our clinical settings today. I mean, in the wake of the CONVINCE trial, and you'll have something to say about that and the basics of hemodialysis. So, Professor, may I welcome you and request you to start your talk, and thank you so much for making this presentation for us.
Thank you very much, my dear friend Khalida. It's my honor to be with our friends in Africa. And I always saying that after a while we have been away from Africa, nowadays we are being in the land we are all belong. So it's always my great pleasure to be here to my colleagues everywhere in Africa. Hopefully that this is our first talk on the hemodialysis committee, followed by, inshallah, with a series of hemodialysis in practice, starting from the basics of hemodialysis and ending by a full training program. Tonight, we will have a hemodialysis filtration in a clinical setting. I will be more slower than usual because it's an educational and we have to focus on each message. So first, we have to go by the agenda. This is our disclaimer. This is the following slides are for educational purpose only, and all data are available from over the net for the further reading. And this is our agenda, which is simply we will go for different hemodialysis filtration. Why? What is the water purification system? The basics of hemodialysis filtration technique, and the expanded or HDF versus hemodialysis filtration. How to choose dialyzers for patients to fit hemodialysis filtration, and our clinical experience in Shamsi University in the reduction ratio, and finally we'll end by the latest randomized control trial. So let us go why we need to do hemodialysis filtration. The uremic milieu and uremic toxins have been expanded too much over the last decade, going from the small solids clearance of urea, creatinine, potassium, and the other very small, tiny molecules, building up to larger molecules need to be removed, and it's correlated directly to mortality and morbidity. So hemodialysis filtration should offer the perfect fit to do a clearance and reduction of the larger uremic toxins have been discovered up till now. It was believed that uremic toxins in the small solids grades is important. However, nowadays we are looking about 50,000 Dalton of uremic toxins, which is the kappa and lambda, being in mind that it's not only related to myeloma. Kappa and lambda retention in patients with CKD and uremic are importantly to be removed because they are related to inflammation as well. So moving from the small solids to middle molecules and the larger molecules, we have to think about hemodialysis filtration. Why we do that? Simply is it correlation of the toxins molecular weight to all-cause mortality and the cardiovascular death. So if hemodialysis filtration improves the uremic toxins, it should improve the all-cause mortality and the cardiovascular death. So why hemodialysis filtration? We are thinking about beyond the KT over V. KT over V simply measures the urea, and we have nowadays other biomarkers that should fulfill the reduction ratio of the major players in the cardiovascular disease and other comorbidities in patients on dialysis. So away far from the beta-2 microglobin 11,000 Dalton to the 50,000 Dalton of uremic toxin, we have to fill this gap of removal by hemodialysis filtration. So in hemodialysis filtration, we look forward for removing middle molecules, small molecules, improving intradialytic morbidity, removing cytokines and inflammation, oxidative stress, improving cardiovascular stability with intradialytic hypotension prevention. So hemodialysis filtration potential benefits are over this function as well in others. You can improve the anemia, nutritional status, endothelial dysfunctions, growth in children, improving the cardiovascular remodeling and the vascular remodeling, better control of volume and the blood pressure. So if this fulfilling for the hemodialysis filtration benefit, we will get the benefit. the hemodiafiltration in Japan, the current status and the future direction are: the molecular weight of solids that can be removed is generally larger in Japan than in Europe. And this may explain why in Japan, the survival is better than Europe and for sure better than in USA. One of the great biomarkers is alpha-1 microglobulin, which is related to inflammatory reactions. It is around 25 to 30,000 Dalton. And I measured it actually in my research, and it is a potential future biomarker instead of KT over V. So we are looking about another biomarker for adequacy in hemodiafiltration. We cannot depend on KT over V in hemodiafiltration for the doses, but additional biomarkers with huge size. It is typically 3x size of beta-2 microglobulin and should be removed on hemodiafiltration techniques. So hemodiafiltration dialysis adequacy should meet the following. Exactly. One, and this is the new adequacy parameters. We have to have beta-2 microglobulin reduction ratio above 80%, which is actually above the urea reduction ratio, 65%. This is one of the items that I should look for in the care of hemodiafiltration adequacy. Beta-2 microglobulin reduction ratio, or a KT over V of beta-2 microglobulin above or equal 1.5. Or a pre-dialysis beta-2 microglobulin below 2.5 milligram per deciliter. So all of these three parameters could be a potential biomarkers for HDF adequacy. Beta-2 microglobulin reduction ratio, or beta-2 KT over V, or a pre-dialysis beta-2 below 2.5. And I will explain why 2.5 exactly. So beyond that, beta-2 microglobulin, again, it's 11,800 Dalton, while urea is only 60 Dalton. So it is huger than urea by thousands of 2,000 of the size. Why beta-2 microglobulin is a good biomarker in reduction? Because it is correlated on the mortality in the era of high flux dialysis. In the latest DOPS, phases from 4 to 6, covering around 80,000 participants with 4 countries analysis, either in Japan, France, Italy, and Spain, they found that a beta-2 microglobulin pre-dialysis above 2.5 will have higher risk of mortality. This ensuring, again, the previous studies saying that beta-2 microglobulin is related with cardiovascular death, and it is also correlated with infection and hospitalization death. So this is why pre-dialysis beta-2 microglobulin could be one of the adequacy new biomarker, because it is correlated if it's above 2.5 with the high mortality rate. In order to do hemodiafiltration, we have to do water treatment. And this water treatment is the largest syringe in medicine. If you are looking to hemodiafiltration, you have a huge amount, up to 200 liters in pre-dilution hemodiafiltration will be used as a dialysate and a substitution. We have 2 kinds of water treatment station. We have the standard, which is the commonest, and the central dialysate delivery system. I will not discuss the standard stations, but will highlight the central dialysate delivery system. In order to do that, we need an ultra-pure dialysate as a substitution for the dialysate, and a sterile dialysate to have such huge infusate. So in hemodiafiltration, we need to have a sterile dialysate defined by an endotoxin level below 0.03 endotoxin unit per milli, and a sterile dialysate with a bacterial limit 1 per million. 0.03 is the limit to detect endotoxin in the by the kids. However, in Japan, they found that they can go down by 0.01. Again, 0.01 is lower than 0.03. And in order to do that, you need to do an ultra-pure water and ultra-pure formation of endotoxin by 2 endotoxin retention filters. We have in hemodiafiltration what is called 2 barriers and the 3 barrier system. 2 barriers mean you need to do by sequential, in serial, and into endotoxin retention filter behind the hemodialysis machine. So this is a 2 barrier system with 2 endotoxin retention, while the 3 barrier system, meaning that plus the first and second endotoxin, you have an additional one, which is the third one, and this third one is this disposable, and typically it is a Baxter system. So if you can use 2 in FMC and other machines, or 3 barriers like in Baxter with a disposable one. In our university and hospital, we are producing the sterile dialysate by using the central dialysate delivery system. And this is inside tubing systems are all in a way of performance. It's composed of a central supply, and this central supply with a central dialysate delivery distributed along all the hemodialysis system with endotoxin retention filter. Behind each machine is a connection coming directly from the central dialysate delivery system in the water treatment station. And we don't use canisters, we only use here salts as bags here to be dissolved in such containers. So the central dialysates are delivered all to all machines. Behind that, we don't use canisters up till now in our university. This is one, I think it's the only study worldwide which I did a couple of years ago, effect of central dialysate fluid delivery system on interleukin-6 CRP level in prevalent hemodialysis patients. And we found that with regular hemodialysis, this is for regular dialysis, not HDF, we found that with CDDS, the endotoxin level after this session is markedly lower than with the regular hemodialysis session. So endotoxin levels are markedly lower in the group with CDDS and higher in the regular water treatment stations. Coming to the second point, what is the basics of the technique? We need several requirements to do hemodiafiltration. We have to know that vascular access is the critical one. Number 2, we have to do sterile dialysate with the spec of endotoxin 0.03 in European and 0.01 in Japanese with colony forming unit 1 per million. Automated control hemodialysis machine with feedback control, I'll come back to that, and dialyzer fit for hemodiafiltration. And this is will come in more detail. So this is the first 4 components with a vascular access, sterile dialysate, automated control of hemodialysis machines, dialyzers fitting for hemodiafiltration. What is the indication selection? It's about 20% of populations on dialysis from the global 4 million worldwide is around 20%, and the perception of that in nephrologist indications are mainly going to dialysis-related amyloidosis, polyneuropathy, hemodynamic instability, 10 years or 5 years more on the dialysis vintage, patients with decompensated heart, patients with diabetes, and the elderly. So this is the commonest indication to do hemodiafiltration among patients on dialysis. With a special application for hemodiafiltration, the cardiac, the elderly, diabetics, malnutrition, kids for growth, and with his healthcare system payments, we have to implement the payments. We have to select from the population of dialysis the required. We cannot apply hemodiafiltration for all. And if we select the patient probably, we have to do either a conventional 3 times per week or more intensified short dialysis or prolonged dialysis. We can build up the convection volume over time, especially in patients starting hemodiafiltration. Depending on the residual kidney function, we can build the dose of hemodiafiltration. So if the patient still has a residual kidney function or starting hemodiafiltration in parameters of increasing the dose, while the kidney function decline, we can increase the dose of the convection. We can use hemodiafiltration in incremental hemodialysis as well in patients on maintenance hemodialysis. So by these publications by Cano, my friend, and Davenport, they supposing that we can initiate hemodiafiltration prescription on naive incident dialysis patients, and this could be increasing the dose and adjusting the treatment schedule with increasing the dialysis convective dose. Then we can monitor. Back again, we have to judge about the convection therapy to the volume of substitution of 23 liters in post-dilutional and on around 50 liters in pre-dilutional, but the biomarker still would be a reduction ratio of beta-2 microglobulin above 80%. If we are using high volume online hemodiafiltration, we can have a convective clearance in the pre and post, but in the post is higher than the pre. We can have diffusive clearance because here is the pre-dilutional mode. So the diffusive clearance is diluted from the pre-dilutional dilatate. We need also a high blood flow. We need an arterial blood flow above 600 milli per minute and an ability to achieve adequate anticoagulation through the HDF mode. So what is the requirement? I need a dialyzer, higher sealing of patients with lower albumin loss, anticoagulation. Remember that if you are using low molecular weight heparin, never to be injected in the arterial. It should be injected directly into the venous because passing through the filter will remove 30 to 40% of the low molecular weight heparin because its molecule around 3,000 to 5,000 only, while the high molecular weight heparin could be injected in the arterial limb because its molecular weight is about 30,000. We need bigger size needles to maintain blood flow, 15. We need a negative pressure of arterial not more than 200 for the blood flow, around 400 milli per minute. Target convective volume in post-dilutional is 23 liters, and you can control sodium, potassium, calcium bicarbonate as parameters. You can use as well glucose to maintain the glycemic control of the patient during the session. So we have to do electrolyte prescription. We can control the bicarbonate, 23, calcium, magnesium according to the patient needs. Usually the calcium is the usual 1.5, potassium between 2 and 3 millimole per liter, and sodium should not be increased above 136. According to the vascular axis, the best with arteriovenous fistula to achieve the target of substitution. So around 86% of patients with AV fistula can reach this target, while in the graph, arteriovenous graph is a little bit lower, but it's okay, while the caster is 33% only. So patients with central casters, double human central caster like Permicast, may not have achieved an adequate substitution of 21 or 23. The reason for that is the low blood flow. We can increase the time to compensate for that. In the last few years, there is an expanded dialysis using the medium cutoff, which is the HDF versus the HDF. And you can have here two of the big players in the field of dialysis, the Pakistan and FMC. Pakistan developed the Theranova, which is a medium cutoff dialyzer, and FMC are pushing toward the hemodiafiltration. I think, to my opinion, both are effective in removal of the uremic toxins, but never mix medium cutoff with hemodiafiltration. So either you have using medium cutoff or using hemodiafiltration, don't mix between. The difference between that in the studies are equivalent in many molecules, like beta-2 microglobulin, kappa lambda light chains, FGF23, YKL proteins. So the difference between HDX and HDS are equivalent. So in countries has no facilities for HDF, they can use the expanded form of hemodialysis or the medium cutoff, but remember that albumin loss with HDX is higher than with hemodiafiltration, approximately about 4 grams per session in expanded hemodialysis. So one of the challenges is using of medium cutoff dialysis membrane, and this is in hemodialysis mode, not in hemodiafiltration mode. And in some of the analysis with US dialysis and other high flux dialyzers against medium cutoff or expanded hemodialysis, removing ratio of kappa and lambda. Here again, we are comparing high flux dialysis, not hemodiafiltration, but the albumin loss with medium cutoff is tangentially higher than for that for loss for patients on dialysis, but still no hypoalbuminemia, probably due to increasing in the nutritional intake of patients on dialysis. So what about the dialyzer to choose to fit HDF? Not all high flux are equal, so we have to choose the best form of dialyzer in hemodiafiltration. So extracorporeal QP should fit with dialyzer. We can calculate it simply by 100 milli per minute blood flow per each 1 square meter of a dialyzer. So if you are using 2.0 dialyzer, you can have 400 milli per minute of blood flow. So this is the equation like that, 200 milli per minute per 1 square meter of a dialyzer surface area. According to the dialyzer type, you have to ensure removal of cytokines and inflammatory mediators. This is the Strug radius of the porosity of the dialysis membrane. So if you are using such like a filter, it will be higher than in the nanometers, and you can remove a lot of toxin, but albumin loss will be higher. So usually we are using what's called superflux. So dialyzer should be suitable for high QP, preferably 1.6 and 1.8, 2.0 and higher. Sieving coefficient sufficient to remove middle molecules. Ultrafiltration coefficient of the dialyzer should be above 50. low internal blood flow resistance before to avoid clotting and clogging, and with an internal diameter of 200 micron to ensure the sustainability and flow smooth of blood inside. So this is basic requirement for surface area, higher sieving coefficient to remove molecules and inflammatory markers, higher KOF, low internal blood flow resistance, and wider fiber internal diameter around 200 micron and above. So this is one of the crucial. Don't use hemodiafiltration in dialyzers with an internal diameter of fiber below 200 micron, because the flow will be interrupted, especially in patients on post-dilutional hemodiafiltration. So we need adequate size with a relatively low internal blood flow and enhancing that in hemodiafiltration clinical performance. Cytokine removal is essential in patients on dialysis. Remember, cytokines are amplifier of any uremic toxin. So biomarkers of uremic toxin, if with the same level between different patients, you will have a different effect, provided that if the patient has an inflammation, it will be an amplifier to the toxin and the effect of toxin will be higher. So it is not simply a level, it's a level and effect. You can remove cytokines by diffusion, convection, and removal by absorption, mainly cytokines because it's a big molecule removed by convection. These are the proposed cytokines. If you look at all above 17,000, interleukin 6, 18, tumor necrosis factor, and other like FGF23. So we are using different fluxes, and this is the area of interest of a super flux that can remove 30,000 to 45,000, and this is the best fitting for hemodiafiltration, and this is the best for Japanese as well dialysis. Myoglobin sieving coefficient is critical because myoglobin is 17,000 Dalton, and if you are using a myoglobin sieving around 0.5 to 0.7, you can remove a lot of cytokines. So this is one of the parameters of the dialyzer choice. This is a size, you can choose size here is 26, which is 2.6, and we have a lot of clinical trials on that. So not all dialyzers are equal in hemodiafiltration, considering beta-2 microglobulin usually between 0.7 and 0.9 tangential difference. But if you are using additional information like myoglobin sieving coefficient, you can find between 0.1 and 0.7. So best hemodiafiltration coming from higher sieving coefficient for myoglobin. This is the Baxter dialyzer, this is a Cordiax, this is platinum, and this is the Pyorema 0.7. So we have a lot of clinical research I published during the last 4 years, and accordingly we are using 2.6 square meter surface area superflux in online hemodiafiltration post-dialysis with minimal clotting inside the filter. Here is from Chance University, the university I belong. We are using 2.2 in post-dilutional mode, adapted for high QP. As before, we said 100 millipairs, 200 millipairs 1 square meter, so we can go up to 400 milli of the blood flow. And you can choose here from this data the dialyzer you can choose, provided that you choose the myoglobin sieving coefficient. For example, the Cordiax here is 0.5 for the myoglobin, while the same company producing FX has the sieving coefficient myoglobin is low, so it's not suitable for hemodiafiltration. If you are going here for Baxter, you found Rivacare myoglobin sieving 0.68, while the polyflux is only 0.37. Better to have dialyzer with a higher sieving of myoglobin. So the prescription of online hemodiafiltration is 23 liters per square meter. So if you have a child or body mass index is small patient, you can apply this calculation in post-dilution mode, 23 liter per 1.73. You have to maintain the filtration fraction, which is defined by the ultrafiltration on the QP. So in order to have between 25 and 30% in post-dilution, so the only way to have a substitution of 23 with higher ultrafiltration rate, you must increase the blood flow. So here you can find increasing the blood flow from 300 to even 450, and subsequently you can increase the substitution from 50 up to 125 to maintain a filtration fraction. So simple calculation is to increase the blood flow to increase the substitution volume. If you cannot do so, you can increase the time. You can increase the time to maintain better hemodynamic, phosphate, and anemia control. Who is the winner? The pre or post or mixed dilution hemodiafiltration. The pre mode is injecting the substitution before the dialyzer, while the post is injecting post dialyzer. To my opinion, post is better for patients with good vascular access, while pre is better for patients with poor vascular access. That's number one. Number two, if the patient needs no anticoagulation, like cerebral lesions or GIT hemorrhage, whatever, or bleeding tendency, never to go post-dilutional because you will need a lot of anticoagulant. You can use pre-dilutional with heparin-free hemodiafiltration. So this is pre-dilution, better in patients with poor vascular access and better in patients needing no anticoagulation. Third indication for pre is the nutritional. Post-dilution lost more albumin due to higher pressure gradient than pre-dilution. So pre-dilution could be applied for patients with malnourished or lower serum albumin. In most of the studies of the pre versus post-dilutional, there is no significant difference in the spent dialysate, but the reduction ratio again, and second part is the serum alpha-1 microglobulin level. So we are focusing here on additional biomarker, which is the alpha-1 microglobulin, which is better in post-dilutional than in the pre-dilutional way. Considering pre versus post, beta-2 microglobulin in the post-dilutional is better than the pre-dilutional, better than in hemodialysis. And KT over V, again, in post-dilutional, better than pre-dilution, and KT over V in hemodialysis is better than pre-dilution because here the diffusion, as I said before, is lower than post-dilution mode because of the dilution of the blood coming inside the dialyzer by a substitution of around 50 liters per 4 hours. What about the hemodialysis machine? Feedback control. The machine should have a feedback control, and this is the automated, typically the automated mode of hemodiafiltration, which feeling the pressure, so coming to do control of ultrafiltration, may have an auto substitution, meaning that if the pressure increase, they push saline or dialysate inside the filter, so clearing up the clogging of the dialyzer filter. Or after control, the same process according to the transmembrane pressure and the pressure gradient inside the dialyzer. And this is a scheme. You can find that. I will not go into details, but this is what's called an automated pressure control of the hemodiafiltration session, because increasing the transmembrane pressure will have not a good outcome. What about our reduction ratio and the publication from my side and my colleagues in the university? We did a series of clinical studies. Again, we are controlling everything of the transmembrane pressure, the dialyzer surface area. We are controlling that of the transmembrane pressure. We are using here 2.2, and you can find that the transmembrane pressure in the 2.2 dialyzer are better than if you are using 1.7 or 1.8. Again, what about the beta 2? It is the marker of adequacy of hemodiafiltration. We can achieve a beta 2 microglobulin of 82% in a single post-dilutional hemodiafiltration using the 2.2 square meter dialyzer. We studied as well the hemodiafiltration in the epigenetics with the DNA methylation and indoxyl sulfate. We didn't find a correlation in indoxyl sulfate. What interestingly, hemodiafiltration improved the DNA methylation and the epigenetic changes, and interestingly, it is related to substitution volume. And this is the only study worldwide that shows that substitution volume can reverse the DNA methylation if you are increasing above 22 or 23 liters post-dilution mode. We are removing a lot of reduction ratio of a lot of toxins like asymmetric dimethyl arginine, tumor necrosis factor. In asymmetric dimethyl arginine and tumor necrosis factor, we can have a reduction ratio very high, approaching that for treatment, and it's better for sure than in the high flux dialysis group. Also, I studied the FGF 23 level and the cardiovascular calcification. We found that we can remove very big molecule in a huge amount in hemodiafiltration in post-dilution method, and this could be found to be a reduction ratio approaching 70%. Again, this is my publication last year, 22, on the American Society of Nephrology using 2.6 high flux dialyzer. Here, this is the first slide to show that, and this is the unique literature on reduction ratio of multiple biomarkers. We measure the kappa light chain. You can find 45% with hemodiafiltration. Alpha-1 microglobulin, remember that this is studied, takes about 3 to 4 years, so in 2019 started. Lambda light chain interleukin 6, 45%, procalcitonin 50% in 4 hours dialysis. Regarding the albumin loss, we found that we have around 2 grams per session. The maximum loss during the first hour, as all the literatures, and the total albumin loss is 2 grams per session. Sclerostin level, I presented this study on USCA, an annual dialysis conference. It's around 2018 and published again in 2020. We can find that we can have a sclerostin reduction ratio of 27% in hemodiafiltration group after 3 months. Final point, what is the latest randomized control trial? It's always shown that from the Catalonian hemodiafiltration studies saying that 23 liters and above will have the best overall adjusted all-cause mortality and cardiovascular mortality risk reduction, infection risk reduction, cardiac death, sudden sudden cardiac death, and this is typically for the above 23 liters of the Catalonian. The convince, how it is convincing or not convincing, I am not so convincing, but it is one of the multi-centers clinical trials, and it's randomized, allocated hemodiafiltration to hemodialysis around equal 1-to-1 and 3 years follow-up. Unfortunately, this study came with the COVID pandemic, so a lot of patients lost during this era. The primary outcome are all-cause mortality, with secondary outcome all-cause and cardiovascular mortality, hospitalization, patient-reported outcome, and cost effectiveness. With sub-analysis published 3 months ago, the majority of patients on convent reaches the 20 liters and above of the substitution, so fulfilling the substitution volume, unlike other studies. And this is for the main substitution. By conventional studies, you can find that achieving high-dose hemodiafiltration is feasible for nearly all patients in the convent. Considering the main outcome, there is improvement in all-cause mortality. However, the cardiovascular one is not so as before, but improving all-cause mortality. Non-cardiovascular is much better. Infection-related and death from COVID is much better in convent. Even, I discussed that with my friend, Cano says that even patients with vaccination has an improved antibody response on hemodiafiltration arm. This meaning that even immunologically, the patient on hemodiafiltration improving the response. So this is the convent. You can find that most of the parameters coming toward the high dose hemofiltration better, especially when the age is below 50. However, on diabetes, it doesn't show much better results, but the majority of parameters are toward high dose hemodiafiltration in convent. So there is improvement in the overall survival of patients on convent, with decreasing the Harder ratio by 23%. High dose hemodiafiltration secondary outcome from the cardiovascular did not significantly affected, not like the Catalonian one. Death from COVID much better in hemodiafiltration. And the unmasking trying again published on November, just 1 month before, to see the spotlight in real world. And they say that in subgroup analysis, the finding of online hemodiafiltration demonstrated more favorable outcome in patients who are aged below 50 and above 65, and who did not already have a pre-existing cardiovascular disease or diabetes. This suggests that high-dose online achieve its better results in healthier population rather than patients with multiple comorbidities. So HDF poised to make its triumphant entrance into the real world still is questionable, and according to the dialysis outcome and practice study, data obtained from the Middle East, it is around 20%, and this trial is still not convincing in USA because USA has some restriction on the substitution volume delivered by filtration techniques through endotoxin retention filter. And from clinical perspective, hemodiafiltration was easily implemented in daily practice by all clinics. Target convinced volume was achieved in the majority, above 23 liters per 1.7. was never associated with any safety issue like fever, ultrafiltration volume conditions, or clinicians or caregivers concerned. Well-tolerated patient dropout from the study was similar in both groups. Again, and lastly, still we are in the field of efficient dialysis between expanded dialysis and hemodiafiltration, and both are two techniques nowadays available and seeming that it's potentially the best therapy for all patients if applicable in the country, feasible for the cost and for patient criteria. And my conclusion, implementing hemodiafiltration should be focused on individual patients' needs and would be best dialysis if we can ignore the cost. High volume HDF can have a better patient tolerability and reducing death by different mechanisms. And thank you very much.
Thank you so much, Professor. I think we have been riveted. I actually am getting so many messages and questions from the audience. I'll ask the audience to start putting in their questions into the Q&A chat. Professor, thank you so much for that amazing presentation. As you said, it was elaborate yet simple and straightforward. A lot of I'll take this opportunity to introduce our panelists who are here with us. The first of whom, very well known to us, is Professor Francois Kaze from Yaoundé, and he is a teacher to us all. I think many of us on this call, that's Victorine and Maimuna, and so many of us have learned from him, so many publications. The head of the nephrology unit at his hospital. Welcome, Professor Kaze. And of course, Professor
Thank
Said.
you.
Yes, Karibu, that is in Kiswahili. Sorry, I've gone into Kiswahili. And Professor Said Khamis is currently the consultant nephrologist at Menofia University Hospitals in Egypt and the head of that nephrology and transplantation unit of a very large hospital, and published more than 50 articles in national and international medical journals. So welcome also to Professor Khamis, who's here with us. Professor, you want to say hello?
You're welcome. Hello, Khalda. Hello, Professor Kaza.
Hello, Said.
Yeah. Thank you so much to the both of you for being part of this. And I'll maybe start with Professor Kaze, who is the co-chair of the dialysis committee under the African Association of Nephrology. And Professor Kaze, we've had all of this information from Professor Hesham, and I don't know what you think in this debate on hemodialysis, high flux hemodialysis plus as compared to hemodiafiltration. What are maybe your thoughts on that?
Thank you, Khalida. I would just want to congratulate Hesham for his nice talk. It was very, very interesting. And then you just go straight forward to tell us, and then to try to convince those who are not, who remain refractory to the hemodiafiltration, not only hemodiafiltration, but high volume hemodiafiltration from the result of this CONVINCE study. I think hemodiafiltration is something like a baby from Canos, and then since I started nephrology, he's the one defending and then try to convince people to move from standard hemodialysis to hemodiafiltration. Before it was low volume, and then now it's a high volume, which show the benefits not only in the clearance of middle molecule, but however, but the benefits of cardiovascular benefits, and then also the benefits from, as we just seen from the CONVINCE study. The major limit for me, in particularly in South Africa, Sub-Saharan Africa setting, is due to the technical problem. Is the availability to obtain a good water treatment unit to have ultra pure water because it is a main challenge in my setting. I can assure you that most of the nephrologists that I discuss with them concerning hemodial filtration, the main limitation is just the water treatment unit. If we can have a good water treatment unit, most of them will move from standard hemodialysis to hemodial filtration, the high volume, because most of the dialysis center now, we use high flux dialyzer, and it's just, for me, maybe those some panelists would say, give their experience. The major limitation for us in sub-Saharan Africa is the water treatment unit mainly. So thank Hesham, and can make some contribution depending on the question from the those who assist the presentation.
Thank you, Professor Case. Thank you very much.
Thank you, Professor Kazi. I totally understand what you're saying, because we have similar challenges within our own country where patients only dialyze twice a week. And maybe they would benefit most from HDF. I'm not sure. I'll ask that question. But maybe, Professor Khamis, if you're able to give us your take or your opinion or your experience as to how your patients have fared with HDF in your unit.
Okay, thanks, Dr. Khalda. Thanks, Professor Kaza and Professor Hesham, for this elegant presentation. I have rather than limited experience right now in Egypt regarding this. I mean, in my unit, regarding HDF, because we have only 2 machines for financial reason and the other reasons, as you know. But I worked in the Gulf area for rather long time there. And really, they use this in a larger scale. I mean, almost 30% of their patients using this HDF. And actually, it's just an observational. I cannot say it is a study, but observationally, I feel that the outcome is better than this conventional dialysis. Other issue also regarding the financial constraints, you know. I think it plays a great role also regarding the limitation of using this HDF in the Middle East and Africa on larger scale, as Professor Hesham and Professor Kaza said, because the financial point, it is very crucial, as you know. If you allow me, Dr. Khalda, I may ask Professor Hesham some short direct questions regarding his talk.
Yes,
it's
please.
Okay?
Always welcome,
Okay,
my friend.
Okay, thank you, Professor Hesham. I will take one by one, if you allow me. Number one, based on convinced study, Professor Hesham, can we say in a loud voice or sound that HDF should be, or in another meaning, must be for all, or still not yet?
Even from convinced and others, and from the dogs, from all other countries, there is still no sharp decision that hemodial filtration should be fitting for all. I was asked before, what do you think about the future of hemodialysis? And I answered in a very big round that the future of hemodialysis is not going for hemodial filtration. The future of hemodialysis is going to cover all patients in need in a local, meaning that you have 4 million patients on dialysis on the globe. Actually, more than 12 million are in need. So the future is to cover all patients everywhere, equality between anywhere in Africa, in Asia, who are poor, has no access. So this is the best. If you are talking about luxury countries, saying that money is nothing, you can go ahead with hemodial filtration because it shows in different studies as a better outcome in all-cause mortality, cardiovascular mortality, anemia control, volume control, blood pressure control, and the other. So it depends. If I'm in Switzerland, you're asking that on the mountain, and I'm skating right now, or shortly after the talk, I'll say, my dear friend Khamis, have a drink, and let us do hemodial filtration. But now, if I'm talking in Egypt, I'm saying that it's costly. And if I go to sub-Saharan area in Africa, I say, oh, hemodiafiltration. What about that? I need to cover 100% of patients on need, saving lives. So it depends the answer on my geographic.
Okay, after the Zoom, I will ask you what about this, the type of the drink, it's alcoholic or non-alcoholic. Second question, what about the outcome of AKI necessitating renal replacement therapy using HDF versus conventional hemodialysis?
Yeah, you mean between intermittent hemodialysis and slow techniques, either prolonged intermittent renal replacement therapy against CRRT or continuous renal replacement therapy. So first, intermittent hemodialysis is the worst in the outcome. But this is the global, according to the cause of acute kidney injury. And if you compare between prolonged intermittent renal replacement therapy, I push here sustained. I don't like SLED, you know that, because it makes nothing. It's called a sustained hemodiafiltration technique against CRRT. Both are equivalent in the outcome, even in systemic patients.
Okay. Third, regarding, is there any, kidney transplantation, is there any study compared the outcome, either short-term or long-term, for end-stage renal disease patients who were dialyzed on regular basis with HDF versus other renal replacement therapy modality, namely BD or conventional hemodialysis?
For the pre-transplantation or transplantation outcome? I always ask this question. No answer, no study saying that. But you know that the primitive transplantation is better than. And so during hemodialysis journey, you have a lot of complications like vascular calcification, you have immune posting or immune reactions, blood transfusion, and so. But if I have a parashot decision without randomized controlled trial, it's a parashot decision, I say that it should be hemodiafiltration, the best option for patients on the waiting list for transplantation.
Okay, regarding the rate of decline of the residual kidney function, GFR, HDF has any advantage regarding versus, conventional hemodialysis?
It should be, yes, because it's more hemodynamic stability. You can control ultrafiltration volume. You don't have a stunning effect, either cardiac or renal stunning with ischemic lesions. You can smooth down the techniques. So I don't have a randomized control trial in my hand, but definitely it should be better.
Regarding the length of the dialyzer, I remember the figure 30 centimeter. The Japanese or something like this.
You are very intelligent.
What about this
I pass this point, but you are very intelligent, yes.
Yeah. What about this issue?
Yes. There is two classes, one of the European class and one the Japanese class. The European class saying that like Kano and the other, and I am from this class because I am research and development of the dialysis membrane 25 years, so I understand that well. Yeah. If you move longer than 30 seconds, you have a struggling of the blood flow inside the filter. You have more shear stress on the fibers. You have more flow resistance, subsequently more dialyzer clogging and clotting. This is the European style. Japanese style, they don't increase the size by the diameter. They increase the size by the length. So you can have longer. I'm against that. I love the Japanese, but I am against this trend. To my opinion, shorter is better because should be more permeable, flow resistance is lower, shear stress is better, and so the outcome and the clogging is better.
Last but not least question, and thanks Khalda for giving me this long time. Okay, removal of ex-uremic toxin by hemodiafiltration or whatever of the extracorporeal blood purification modalities can guarantee improvement in the outcome, namely mortality and morbidity.
Another intelligent question, my friend. I can explain for the juniors. What is the definition of uremic toxin? You should fulfill 4 things to define uremic toxin. 1, it should be chemically identified. Correct? Yes.
Yeah.
Number 2, it should be higher in patients with CKD or end-stage kidney disease more than patients on volunteer or portion with normal renal function. Number 3, you have to be defined how to remove. And number 4, that the removal should be applying to improvement of the disease. And that's why not all are supposed to be uremic toxins. If you analyze the filtrate from the filter on high flux or hemodiafiltration, you can find that more than 1,300 molecules present in the filtrate in uremic patient, not on the volunteer. So all of them are correlations, no direct effect. You cannot find, you can say that, pentrexin and endothelial dysfunction, protein-bound uremic toxin and the cardiovascular, SCGF23 and left ventricular, but you cannot find a direct disease related to each individualized toxin.
Thanks, Professor Hesham. Thanks, Dr. Khalda, and thanks, Professor Kaza. I'm sorry for taking a long time, okay?
I enjoyed it.
Yeah.
Professor Khamis, I think we've enjoyed that exchange so much. I think it has answered so many of our questions. It's like one after the other. And I love it because there's one question over here by Wesley Tulekan who's asking how HDF compares directly to PD regarding mortality and transplantation and quality of life. But I don't think we have any direct comparisons, do we? Though to all of us, HDF makes sense technically.
Yeah. Yes. Even hemodialysis or even combined hemodialysis and peritoneal dialysis, what is the mixing renal replacement therapy, there is some literature saying that mixing is good to maintain patients once or twice per hemodialysis per week, and the effect. It makes sense that it's a good approach. If you are doing hemodialysis is not a single treatment. You can say globally a hemodialysis and BD. What is the hemodialysis prescription? What is the dialyzer use? What's the water treatment? What's the duration of dialysis? What's the residual kidney function? Is it superflux or low flux? Even in BD, you can say that what is the fluid of BD, what's the range of changing bags, and what is the patient. So I cannot say Ferrari is better or the Porsche is better, because we cannot compare both of them. But regarding the outcome, both of them have the same outcome if it is done by the best practice.
Okay.
Professor Khamis, you had something to add to that?
No, okay, I do agree, fully agree. Okay, thank you.
I think one of the things that I will just comment on, and there was a question here regarding albumin loss and functional anemia. This is from Masoud Khairi and from Khalid Abduzaid. And these questions were regarding microalbumin as compared to albumin loss, microglobulin versus albumin loss, and about functional anemia management. But just for us, even within the CONVINCE trial, Professor Hesham, CONVINCE didn't show any difference in hemoglobin. It didn't show any difference in phosphorus. And one of the things we would be interested in, for example, Professor Kaze has done some work on malnutrition and HD in children, if I'm not mistaken, Professor Kaze. But Professor Hesham, we would not recommend, as you said, would we recommend HDF in patients who are already malnourished and who we were worried about a malnourished patient? And correct me if I'm wrong, but we haven't really noticed much difference. There's some trials, but not in CONVINCE definitely, regarding anemia. And what would you say about beta-2 microglobulin versus albumin loss?
So it is it's a multiple question inside one. So number one, malnourished, what is the first? It's a chicken or the egg? Is the patient malnourished from inadequate dialysis or malnourished from additional factor? If it is malnourished from inadequate dialysis, definitely hemodiafiltration will improve. It's supposed to remove more toxins, protein pound will be absorbed, and additional leptins and like that, and improve the nutrition. If you are fear, I said that if you are fear of albumin loss, you can use the pre-dilutional mode. So there is no contraindication in malnourished patient or elderly or young or female or male to do hemodiafiltration. So if you are showing that patient needs more nutrition state, you can have a supplementary, even oral supplementary. I give oral nutrition support by amino acids for patients that fearing of albumin loss. I can give pre-dilutional mode because albumin loss is nothing. Coming to second question, is it improving or not improving anemia? Yes, there is a lot of improving anemia. Considering albumin loss, I had a sentence, it is 5 years ago. Now it comes to the light. But I am talking about that 5 years ago. And even I discussed that with Professor Cano and Dr. Kelly on that, on Milan. We should remove some albumin. Because one is albumin turnover by the liver is 14 to 15 grams per day. If they have an amino acid. Each one molecule of albumin is 585 amino acids. Number two, albumin in uremic meals are glycated. So a lot of glycated albumin we have to be removed. Number three, protein pound uremic toxin will not be improved if you remove some albumin. The question is to remove or not to remove. I am calling that it is a bad albumin and should be removed. The problem, how much I should remove. According to Japanese and the clinical studies, up to 3 grams is better to be removed during the session. Above that may be of nutritional issue.
Interesting. That brings a whole other component. And I can see actually we are out of time. We have gone beyond time. And in the interest of everybody getting home, I will give you one last question, Professor Hesham. And this is again from Khalid, which is, I think he's talking about the super dialyzers. He says, are we near to reach to more compatible semi-permeable charge membranes, such as nephron membrane, for better selectivity and differentiation between bad and good? What is good for clearance? So maybe you could answer that question, Professor?
If I understand well, you are selectivity on charge.
Yeah, I think yes.
Yes, it's one sentence. All dialysis membrane are blind. They will not select. What's in the size will be on the pores.
Yes.
You can improve the hydrophilicity. So hydrophilic membranes will have lower protein fouling and protein absorption on the wall. But what's saying how it is selective remove of the same size, it is not present up to now in any blind dialysis membrane. But it's more hydrophilic, lower thrombogenicity, lower protein fouling or clogging. So this hydrophilic membrane is better.
Wonderful. I think I'm going to leave it at that, Professor. I think we have a lot to think about. I think we've come out with a lot of questions and answers, but definitely a lot to think about and definitely better educated than when we came into this webinar. I want to thank you so much for taking your time to talk to us about this, for taking the time to prepare this amazing webinar. I want to thank Professor Kaze and I want to thank Professor Khamis for their time, for coming in to discuss this with us and giving us their expertise and experience. And I want to thank our audience for joining us and for the wonderful questions. And I will say, let's go and think about it. And let's, I've already challenged some people to come up with some data. And hopefully we should be getting back to you all soon. So thank you very much. I'll call this webinar to an end and bid everybody adieu and a good night.
Thank you very much. Very nice meeting. See you soon.
Yeah,
Goodbye.
good night. Okay,
Thank you. Goodbye. Have a nice time.
You.
Goodbye.
Bye-bye. Bye-bye.
Bye-bye. Bye-bye.